Hi, everyone. I think I'm going to get started because I think we started the broadcast. Thanks for coming today to hear our presentation. My name is Sarah Kirby. I'm going to do the first part of the presentation, and then my colleague Jeanette Edwards from Shared Health will come in and talk a little bit about how it links with Shared Health and the work they're doing. I work at the George and Fahey Center for Healthcare Innovation, and I manage their health systems performance platform there. And the Center for Healthcare Innovation has kind of taken the lead on moving forward with this initiative and sort of guiding it forward. And we're doing that in collaboration with a lot of partners in Manitoba, but in particular Shared Health. And Jeanette is here. She is the strategic lead for community health, quality, and learning for Shared Health, and the project lead for the quality and learning framework there. So we're going to talk today about patient-reported outcome measures. How many people in this room have heard of what PROMs are, otherwise known as PROMs? We have a few. If you were to rate yourself from I'm an expert at PROMs to I really have no clue what PROMs are, how many people here would consider, like, I do research in this area, I know what PROMs are, I'm like getting into the, well, I really know PROMs range? No hands. What about the I just have heard about it, I really have no clue what PROMs are range? More. And then so everybody else somewhere in the middle. Okay. The acronym. Yeah, the acronym is thrown out everywhere, and that's why I think these presentations are good, because even when I started working in health systems performance, that's not my background, it's public health, but I just kept hearing about PROMs and PROMs and PROMs, and I'm like, what are these PROMs? And like, anyway, today we're going to learn what they are, why they're important, why we think we need to use them, and have them as a central part of the way we measure healthcare in Manitoba. Before we do that, though, we need to talk about how do we measure health systems performance currently. So currently, we tend to use really easy to measure things, outcomes, easy to measure outcomes like mortality, like hospital discharge data, like important biomedical indicators of success, like your blood glucose level, your heart rate, your blood pressure. And these are all really important outcomes, but they don't always provide us all that is important to the patient. The real measure of health systems performance is whether we're helping people recover from illness, live well with chronic disease, and face the end of life with dignity. And we can't know if we're really achieving that in our healthcare system unless we ask patients, unless we ask people. So this idea that measurements of success in terms of improvement in patient health status or health-related quality of life is fairly rare. Outside of clinical research, it's rare and only done in little pockets and not collected systematically in Canada yet. So one of the areas where PROMs are collected quite a bit is around managing chronic disease and chronic conditions. I don't know what it's like to care for a child with complex medical needs. I have watched my good friend try to navigate the healthcare system with a child with a rare genetic disorder and multiple complicated disabilities. And it's a healthcare system that tends to be fragmented and divided into specialties that are very focused on their specialty-specific outcomes. And these are outcomes like organ function or response to medication. Again, really important outcomes, but what we find is that they don't always capture, as I said before, all the outcomes that are important to families and to children. In fact, when asked as part of the Children Outcome Measurement Study, children and families reported that it was really quality of life indicators that were most important to them. Things like their emotional well-being and family and friends. And they were really only interested in other health outcomes because of the way they had an impact on their ability to achieve their quality of life outcomes. In contrast, health professionals, organized again by medical specialties, focused on very narrow and specific outcomes related to their specialty and often more biomedical type outcomes. And it wasn't always clear in this study how these supported the outcomes that were most important to children and families. So the results of this research was used to inform the National Health Service, the NHS's outcomes framework. And that framework includes PROMs, patient-reported outcome measures. And in fact, the NHS has really led the use of PROMs, and they collect PROMs across many clinical areas and use it as a central way of the way they measure health systems performance in the UK. We don't do that. That's not part of our measurement framework in Canada, but we are moving towards that. So, but we still haven't said what PROMs are yet. So does anyone here want to try to guess what they are? Does anyone want to take a guess at defining what a patient-reported outcome measure would be? Nope, that's okay. I just didn't know if you wanted to get engaged a little bit this morning. Okay, their tools are basically questionnaires that are used to ask patients about their perspective on the outcomes of their care or the outcomes of their treatment. And they usually capture quality of life type information, things like functional status, physical, mental, and social well-being. And they are questionnaires, they're standardized questionnaires, and they're information directly from the patient without any interpretation from another health care professional. And like I said before, they are used, they're used extensively to measure the success of some healthcare systems in the United States, quite a bit, the NHS, and also many health systems in different parts of Europe. And they're becoming more and more, we're becoming more and more aware of the benefits. So some of the obvious benefits is that we can't know whether we are providing health services that provide outcomes that matter to people who pay for healthcare unless we ask them if we're doing that. And in clinical research, we find that it's amazing how the outcomes that the clinician thinks are important in the research, when we have patients involved in that research, how they can point out outcomes that the clinician themselves didn't even think would be an important outcome. So we know that patients and the public have outcomes that we may not even realize are important, and we're focusing our energy and our time and our money on different outcomes. So in other areas, I mean, research, we've been using patient-reported outcome measures in research for a while, but imagine collecting them centrally and linking that data to important administrative data that we collect through the Manitoba Centre for Health Policy, or demographic data, or clinical data in real time. Imagine the research potential there. I already mentioned how they can really inform quality improvement in ensuring that we're delivering the service that we say we're going to deliver. They are also used to measure value in healthcare, where that's moving away from looking always at the volume of service and more towards the quality of the service provided as defined by the patient or as defined by the public. And finally, they're used to enhance patient and clinician communication and plan patient journey type activities, like the care pathway for people in chronic conditions and cancer and things like that. So this is the main reason why they're collected, and I'm going to just use a local and national example to highlight that. I seem to be missing, oh no, not, okay. So one clinical area where we've had a lot of experience and we use patient-reported outcome measures is in hip and knee surgery. In Manitoba, we are kind of leading this work, actually. We have been collecting patient-reported outcome measures for a few years now. We collect them preoperatively and 1 year postoperatively, and we use them for clinical decision-making, quality monitoring, and research. They're combined with other data from medical hospital records and waitlist data, and they're combined to generate reports that are delivered to the surgeons and to the hospital sites, basically to measure quality. So the reports are reviewed by the orthopedic standards committees, and anybody who is outside of the regional average for more than 2 years has to meet with the quality committee. And they actually have had to meet with surgeons and have seen total changes in surgical behavior as a result of that. It turns out that people want to do a good job, and when it's pointed out that you're maybe not meeting the average, that physicians and clinicians tend to change their behavior toward that. So they did they took a look at their data, this is just an example right here on patient satisfaction rates. And after, so they started collecting PROMs, and then after their intervention, which was to report quality reports to the sites and surgeons, they saw an increase in patient satisfaction rates. They also saw an increase and an improvement in quality indicators, things like a decrease in transfusion rates, length of stay, and complication and revision rates in hip and knee replacement. So this is very promising. Now CIHI, the Canadian Institute for Health Information, has developed a standardized process for collecting and reporting patient-reported outcomes in Canada. And so this is the first national standardized process. They have released a manual, and now they're able to compare data across provinces. And this is ultimately where we hope to go nationally, and we're moving forward with some other areas. So that's just an example right there of how PROMs can be used to facilitate value in medicine, to facilitate quality improvement, and they also used some of their results for research stuff. So patient-reported outcome measures are divided into two types: generic, which asks the same questions across diseases, and so that you can compare results across different disease groups, and condition-specific PROMs, which are obviously just specific to that disease. So they have a lot of value in giving you good information about that disease, but they can't be compared across groups. So usually you collect both. An example of a generic PROM is the EQ5D, 5L, also the SF13, FS36, sorry, the SF12 and the SF36 are two other common examples. I'm providing the EQ5D as an example because this is what we use nationally, and we're very likely to be using this provincially. We have access to licenses to use this generic PROM. And this is just a quick example of a disease-specific PROM. Again, patient-reported outcome measures, there are hundreds now that exist. This has been around for decades. And what they're validated tools, and we have big databases of these tools. And so this Oxford Hip Score is what we use in orthopedic surgery, and it's a well-validated tool. It's now used across the world. It's not used in absolutely every country, but we're moving not just towards like a national standardized approach, but to a global standardized approach. So that's the idea of the PROM, is that we are using a validated standardized measure. So you may have also heard, just to cap off the background part of this, you may also have heard about PROMs. How many people have heard that acronym thrown out? You've heard a lot about the PROMs, but PROMs are patient-reported experience measures. They're also very important. The focus of our work is really looking at outcome measures, but they often go together, and they are more focused on what the patient's experience of the service was like. So things like bedside manner, or how easy was it to understand information, or that information was presented in an easy to understand way, timeliness, cleanliness, those kinds of things are collected using patient-reported experience measures. So today we hear a lot about patient-centered care. We talk about it a lot. Right now, as we transform our healthcare system, we are talking a lot about transforming our system into one that is more patient-centered. And we know what that means to Canadians because we've asked Canadians in the Healthcare Canada survey. We know that Canadians define or aspects of patient-centered care to them is care that is provided in a timely manner, that they have timely access to care, that there's perceived respect and caring in its delivery. Decisions are made in partnership with the healthcare provider, and it's implemented within the basic belief that should be based on the patient's need and not the patient's ability to pay. And healthcare providers feel the same way about these points. They just include that it should be evidence-based as well, which makes sense. But a lot of people do argue that while these are very important aspects and Canadians would want their healthcare system to be like this, we don't have the ability to capture or ensure that we are delivering those aspects of patient-centered care, and that patient-reported outcome measures are really an essential part of patient-centered care. And this model helps to just really give a visual representation of what that means. I think that sometimes healthcare providers get really defensive when we talk about that, because everything we do for the betterment of patients and the people that we work with. And we don't often see where we're not actually providing patient-centered care. We've been providing perhaps patient-focused care, and we need to make that leap. And part of making that leap is involving patients in the way we measure patients in the public and the way we measure healthcare. So I'm going to pass the microphone over to Jeanette Edwards, who's going to talk to you a little bit about shared health and how patient-reported outcome measures fit into moving forward with some of the goals that shared health currently has.
The good news is I'm speaking to folks who are familiar, but Sarah and I have been working a lot on this together, and I think just as a background to you that now that we have this quality and learning framework, and certainly SSCY and Rehab Center for Children have been the exemplars in applying the framework, and now you're going through accreditation and you're hearing that language, patient-centered care. So we're really working hard at ensuring that PROMs and PREMs are seen within a context. PROMs and PREMs will be a huge tool as we move forward with the framework, which you've all seen. In the middle of that framework are enablers. And so again, here's where PROMs and PREMs, it's really important for us to understand how they can fit, and also to understand what types of skills and enablers do we need to move forward. So certainly leadership and a shared vision. Some of you may be interested and are aware of the LEADS framework for leaders, and we're planning more and more education in that area. But we've now mapped the quality framework to lead skills, and how important it is that we really develop leaders in our system who can embrace a lot of these concepts. We talk about performance measurement, and as Sarah said, we have lots of performance measures, and some of you also may be aware that there is a provincial dashboard that each of the regions mandatorily have to submit to government every month. I think we'll see more of those. And there's 4 key indicators, and one is patient experience. And to date, the only patient experience that we have is in acute care. So CIHI actually has a survey. If any of you have been unfortunate enough to be an inpatient, you will soon find that you get a questionnaire in the mail that asks all sorts of questions about your experience. And here's the opportunity we have to now talk about patient-reported outcomes. What we do with those outcomes are going to be important. So as we hear things, so I'll think about PREMs in acute care, we're hearing all sorts of concerns about transitions of care. So we still very much do section by section. We talk about hospital care, we talk about community care, and a patient I was meeting with this week says, I'm the only one that can tell you about the system of care. So here's where PROMs is also going to be very important as we move forward, particularly with all of the health system transformation. And standards, you're now very familiar with standards, particularly with Accreditation Canada. There will be increasing licensing standards. We're seeing the regulatory bodies coming forward. And some of these certainly also relate to patient-reported outcomes as it relates to systemic equity and so on. Very quickly, I'm just going to go through the quadrants in the framework. The first quadrant, not that they're in priority, is certainly about populations. And in this one, I'm just going to focus on equity. Patient-reported outcomes has not been used a great deal in equity and also in helping us address systemic racism. I'm very aware of the work that's gone on in the center here, and you certainly are leading the way on how do we look at equity, how do we look at issues, how do we create an environment that is one of inclusion and diversity. The positive patient experience is a very deliberate quadrant in the framework. This is also certainly supported, and we've overlaid with this the IHI quadruple aim. The standards in the future for accreditation, but also others, is no longer going to say with client input. It's actually going to move beyond input and engagement to involvement. And I say that having sat at a national table and seeing clinicians and several family physicians that were actually at that table who were absolutely shocked at the idea of the patient being a team member. And that wasn't, and I don't say that in a judging way, but we have often gone through our system thinking input is, well, I ask the patient, or involvement is shared decision-making. So when we start looking at PROMs and PREMs, but particularly PROMs, there's a huge opportunity for us to hear that patient voice and then involve the voice. And I'm saying that as we move into how to use PROMs. It's not just going to be another standardized questionnaire, of which there are many, but really creating the ability within our teams to understand what information is there. Continuity is another domain, and I'm just going to focus on that one momentarily. Care continuity is now being identified as one of the biggest risk factors in our health system. So when I was at a meeting and actually with Brock Wright, and I said at the group, are you aware that the third leading cause of death in Canada is actually preventable harm in hospitals? And people are just shocked. I mean, so outside of cardiovascular disease and cancer, the system's actually the next leading cause of death. And that just includes inpatient care. So when we start looking at PROMs and hearing patients, I think we've just got the tip of the iceberg. So the biggest risk, and if we start involving patients, is actually the transitions. The transition from a hospital bed to home, the communication, the outcomes, the pharmacist, the private system, and it's very, very interesting by involving that patient voice. As we're moving forward with the clinical plan, and so that's been released since the last time I've seen you, so it's posted if you're interested. But you'll find in the clinical plan real system transformation plans that are going to be underway. Certainly one of our key areas is going to be community health, home care modernization. You'll hear that language. And the key to that is clearly going to be patient-reported outcomes. When we say patient, I will include family in that, so in case you're asking or thinking. We'll be moving forward in Manitoba with clinical governance, provincial clinical networks. They will be interprofessional and they will be provincial. So as we're moving forward, clinical standards, standard clinical pathways are going to be essential. So how many times do we know of referrals that are shotgun referrals, hoping somebody will answer a referral or a consult? And where do patients actually fit in that piece? So what you will be seeing is the clinical plan implementation will be done through clinical networks, and we're beginning to pull PROMs and PREMs into the measures. So with every transformation we're doing in this province, we need to set targets, and those need to be qualitative and quantitative targets. The last comment I'll make is we're beginning to start seeing some real unique opportunities around PROMs. So we're working a lot with primary care. Some of you may have heard of my health teams. In the clinical plan, you'll see local networks. And there is a pilot that we're doing actually at Pan Am Clinic. So again, related to orthopedic surgery because there's some expertise there. But what may be of interest to you is that we're testing also software called Ocean, and it's linked to Accuro as we look for also ways to collect PROMs and to move forward. So knowing that you're also familiar with Accuro, I thought I'd just give you a bit of a snapshot of what's happening. Sarah.
So as Jeanette said, we want to start using patient-reported outcome measures in the way we're measuring healthcare in Manitoba. So we have a vision. This is a brand new project. We just started putting this idea out and got a really amazing response from our key stakeholders. And we formed a provincial advisory committee around this work. Big question though is how are we going to do this? Because it's big and it's complicated. So I will get into that a little bit, but this is just a little framework to start us off. We obviously need to engage various stakeholders, and there's a lot of key stakeholders, as I talked about earlier, because there's value to a lot of different stakeholders using PROMs, whether it's the patient, clinician, health systems manager, researchers, they all get real value from PROMs. So they're all key stakeholders in this. We need to determine where we start in Manitoba. What are our priority areas? Where can we leverage projects and work that are already going on so we can identify easy wins, demonstrate feasibility and scalability. We need to decide what measures, what PROMs measures we're going to use. So we've already talked about the EQ5D5L. I think we're going to know probably that we're going to use that. Is that sufficient across the board? What kinds of generic PROMs or condition-specific PROMs are we going to use? That depends on where we start, but those things are really important for us to start to understand. How are we going to collect this data? It's collected by paper-based questionnaires in hip and knee surgery, but there are all kinds of ways, and there are pros and cons to all of these ways. There's electronic way to collect them electronically, and Jeanette talked about that. We're piloting an electronic platform to collect PROMs in the waiting room, but it's also, you can collect them by telephone, by interview, one-on-one interview. It really depends on your audience. And again, there's pros and cons to each. There's also important regulatory and privacy considerations, accessibility, language, and culture considerations when it comes to data collection as well. And then what about reporting? How are we going to use this data specifically? Are we going to report it publicly? If so, what do those reports look like as opposed to reports to clinicians? Are we going to use them for performance management? These are the main components of the how that we need to work on as a group as we move forward. So for us, for our immediate next steps, of course, the first one in that framework was the stakeholder engagement. And for us, stakeholder engagement really also means public and patient engagement. So we have started that process of engaging the public broadly on this topic. It's a little difficult at this point because it's a bit of an abstract concept. And until we kind of know where we're going to prioritize, I think that's the best time to start engaging specific groups of people with lived experience in that area. But we have started with some public engagement. We had an event on October 30th that was kind of the launch of this idea. It was a 2-hour forum on PROMs at the Bannatyne campus. Did anyone attend that forum from this group or hear about it at all? Okay, so it was, again, like a launch to introduce this idea. Brock Wright is our clinical champion for this project, and he was moderating this event, and we had 7 speakers who have some expertise around PROMs within the province, but also nationally and internationally in terms of the work they've been doing with PROMs. We had close to 200 people attend this, either by webcast or in person, which we were a bit surprised by, and But we thought, this because because we're ready for this in Manitoba, and it is a really important thing to do. And I think people are interested in how can we do this and how can I be part of moving this forward. So the other part of stakeholder engagement that we've just started with, we do have an advisory committee of about 15 stakeholders, including members of the public, and a range of, we have regional representation, we have representation from various research groups in Manitoba, from Manitoba Health, from Shared Health, Cancer Care Manitoba, Primary Care, and we have data analysts and data scientists around that table too, because obviously that's a key component to this. And we've also started some consultations with different clinical areas, as Jeanette was saying, primary care, but also chronic disease areas. So the next immediate next step is that we need to figure out where we're going to start. And for us right now, really, what's the important places for us to start, considering we're moving forward in Manitoba, where we're not probably spending a lot of new money, but we're leveraging resources that we already have. And so that's how we have to start. We have to identify areas where suitable infrastructure already exists, i.e. orthopedic surgery. So build off of areas where we can identify easy and early wins to demonstrate success, but also we have to focus on our provincial and national priorities as a place to start. So we're kind of working on those priorities now. And then the immediate next step, which we're just barely dipping our toe into, is we need to figure out how we're going to demonstrate success moving forward, so that we can continually leverage that. So we're looking at implementing this in small steps, assessing how it works, expanding from there, and moving forward, given the environment we're in. So these are the areas, and I know that Jeanette did talk about a few of them. These have been identified as areas that are already sort of moving forward in this direction. Like Jeanette, you were referring earlier how we're just kind of running behind the train on some of these. Like, things are moving forward, and we're trying to do the best we can to align some of the provincial priorities around the collection and reporting of PROMs, and find PROMs tools that will work within the evaluation of some of these programs, whether it's primary care or chronic, in this case, chronic disease, the tick-borne disease program, but there's other programs that they're moving forward with quickly. And the final one I'll spend just a little bit more time on is this bottom one, which is demonstrate within the mindset trials. Does anyone have any idea what the mindset trials are? Okay. Well, we're having a round February 13th, I believe it is, at the CHI. You can learn more at chimb.ca. But mindset is a very large, very well-funded trial in Manitoba. It's received I think I've heard it's the most funding ever from the Canadian Institutes for Health Research, and received match funding from Manitoba Health. And the Mindset trial is working to integrate selection of currently isolated clinical databases to facilitate 3 innovative clinical trials in order to demonstrate the importance and utility of having integrated clinical data. So just to back up a second, in Manitoba, we have lots of clinical data. We have great clinical data. They're in disparate databases all over the place, and it's really hard to access them. And we're not actually one of the best producers of research in Manitoba. We're actually pretty much at the bottom in Canada. So one of our goals from the academic center is to increase that. And I think the goal of this and the point and the primary investigator, Dr. Ryan Zarychansky, is really trying to push Manitoba to understand that there are so many reasons why putting our databases all together in one centralized, integrated, efficient clinical database will serve us in so many ways, not just in research, in all kinds of ways. So this is like the visual representation of this, and we are going to be part of this to talk about how we can integrate patient-reported outcome measures, and we're going to try to demonstrate feasibility and scalability by attaching ourselves to the 3 trials, innovative clinical trials that they're doing. Most importantly, It's the CAPTAIN, the cancer patient journey trial, and the other trial, which is Home First, which is home dialysis, implementing home dialysis. So this just gives you, again, a visual representation of the trials, and it's a real amazing opportunity for us to work along with this project to try to, again, demonstrate feasibility. So that's the end of our presentation. I mean, we're very excited and feel that this is very important, and that it really signals this shift that I was referring to in that other diagram of one that is from a system that tends to be more disease focused, and not because of anybody's fault, but that those are the measures that we tend to collect to measure whether we're doing well. Moving from a disease focused healthcare system to one that is really focused on patients and the public and what outcomes matter to the patients. So I'll take any questions now. Jeanette and I can take questions.
So thank you both for a really interesting presentation. So while you're working at a provincial level, if there's individual organizations or services, so you can see a lot of people from rehab engineering here, for example, that want to start looking at some of this kind of a small clinical level, where would you suggest that they start?
So I will take some responsibility in getting Sarah into all sorts of trouble. So something small, and if you look at the examples up there, so the tick-borne disease, my health teams, what I'm finding is as people are wanting to do evaluation and include the patient, that's when I'd be tapping Sarah on the shoulder saying, can somebody meet with us? So we're embedding PROMs into our evaluation. So for the tick-borne illness, for those of you who don't know, this is a brand new integrated service for Manitobans. And I was keen to develop an evaluation framework where we actually start the service to get ahead of it. And in doing that, we had somebody develop an evaluation framework, and I immediately say we need to ensure the patient's involved, and then find out what tools are out there that are standardized that may be applicable. So, and we've just done the same with my health teams. So as we're evaluating my health teams and patients' access to service, it needs to be from the patient perspective. So we've been trying to share with that group, here's some standardized questions. And so it's just finding those opportunities.
And I'll just add to that, because we are really encouraging any side project research projects, and we hope that some will come out of this. And I think what you may be talking about is like a little bit of research in a specific area that's not provincial. I think that's what you're saying, right? Like how can someone get started? And
yeah,
there's
no reason we can't be.
That's right.
Some of this information, using it ourselves. Eventually, it might roll up to a provincial database, or
examining that. Okay, so there's, I mean. Okay. So like Jeanette said, there's a couple ways. So it's not just research based, but organizational based. I mean, you can come to us and we can help you locate standardized PROMs that are used in areas and facilities similar to yours, things that have been validated, and you can determine whether those tools work for you. Because like Jeanette's saying, what we want to make sure we do is not invent 8 different wheels. Like we want a standardized approach. We might as well start with at least looking at the outcome measures that are the ones that are most likely to be used globally or nationally, and then start testing the feasibility, start testing the usability of that within your world, and like in a small way that we can maybe eventually roll up, like you said, as we make advances on collection methodology that links right with the electronic medical record. You know, as we move with that provincially, and you're moving with a smaller project more in your clinical area, that can feed into the provincial program later on. So best start is to identify outcome measures that are being used globally, and there are many. So I mean, I'm happy to help you get started with that. Or
working with children, often you'll be posing the questionnaire probably to the parents. But there are some kids who can communicate on their own, but and maybe it's more difficult. They might have a different answer than parents. So, do you know how you deal with that, or are there other difficulties you see in working with?
It's not my area of expertise. I don't know how you deal with it, but I know others know how you deal with it. And in doing a little bit of research to familiarize myself with some of the PROMs work being done with kids with neurodisabilities or multiple complex medical needs, I saw a lot of work, especially out of the UK. And so I think just there has been work, and I do think there's a lot of learning that's gone on. Like, okay, that didn't work, or we collected those, but that's not valid because, yeah, we got different responses. So there are interesting approaches, and there are people who are doing this work out there. I'm just not hugely familiar with that.
Really informative, and I'm glad I know more about the acronym. I think I was intrigued a little bit about the comments around some of our care providers, still struggling a bit with asking a patient versus involvement. And I think one of the changes I've seen in some of our community partners and our mental health partners is actually eliminating the word patient, which itself has a pejorative connotation, moving towards either participant, client, and certainly many of our families here at SSCY will say, no, patients are not really sick. This is who we are every day, and we don't use those words. So I recognize you can't change a national thing, but it did, for me, coming from an acute care system, it took a lot of changing, my outlook from even the word patient to the word, again, client or participant
or partners, yeah. Yeah, we've heard the same thing. Yeah, absolutely, we've heard the same thing. I mean, we're a SPORE-funded entity, the CHI, that is, we get CIHR funding for patient-oriented research. And so we talk a lot to patients and the public. And for this, I really felt like when I'm going out to the public, I try to talk about public engagement, because it's all of us. This is our healthcare system. I need to be able to tell you what's important to me. I'm not a current patient, but it's still, so it is true. We really got stuck on this word and of patient, and yeah, you're right. With PROMs, that's the acronym, and I can't change that, but the way I market it and talk about it publicly can definitely be, that we found the very same thing.
Debate will go on forever, and I think it's important to be very aware of the different situations that people are in. And for many First Nations communities, because I do work in the North, climate is not essential. It implies a power of knowledge. And so, I think these are all learning. So it needs to be very situation specific. The important thing is that the recipient of service person is involved. So we'll work around. But I think, Cheryl, going back to one of your original questions, is awareness, for me, has been the breakthrough. And now, as things come up, like when my health teams are going to do patient surveys, I immediately called Sarah and said, can you come and meet with this group? So will they adopt all questions? But it's one of them is a perfect opportunity to expose that group to PROMs, the concept. And we were able to connect them with some standardized questions, how they perceive it, to take an enabling approach.
In pediatrics, we've always had the advantage that families are an integral part of the care of the mother, and thus I think the semantics become even more important to us, because the family is really seeking service, not just the child, and we get different answers from the parent, because we hear from the child. And I think that we're moving away from the
family-centered, family-integrated care. And I think that in child care, the family has always been more integrated into the healthcare system by necessity of seeing the proxies for the child. So I think that in many ways, we have an opportunity to do specifically to look at ways of integrating families that are novel and that have an opportunity to partner with you how we can bring those thoughts and back. Because I think that we're all places we
This may not be a fair question, but can you talk a little bit about how the PROMs sort of integrate through the flow through services? Like when these are implemented, perspective, somebody arrives and they go to child development clinic and get a diagnosis of autism, and then they go down the hall to feeding clinic and are seen there for something, and then they come upstairs to assistive technology. In the process, like is this just a survey that happens in the mail after they've been here?
Actually, that's a really good question, and I would have to read in what they do in the UK, but I think they've used it to try to better integrate care for one thing, but I don't know how they use it, but it would be really neat to find out. I'm sure it's complicated, and they probably had to put a lot of thought into it. But every program, every clinical area is different. Like I said, in hip and knee, it's literally a paper-based form in the waiting room. And then a year later, you get mailed one. So, I mean, I don't know if that is ideal, but for them it is, it works. But that wouldn't work in this situation probably. Like,
that's a really concrete service. Really
right. Yeah.
So I'm just curious how it works in a flow situation.
I don't honestly know. It sounds complicated. And I know that the data collection piece is going to be complicated. Like I said, some of the things to consider aren't even just the flow stuff, but language and accessibility are things that we need to really consider, and cultural appropriateness. And because if we don't address those things, we're going to systematically exclude those people from the data we collect. So there are all kinds of things we need to consider. I don't know how to answer that, but you're right. It's not a one size fits all at all. We can try to create some one sizes that makes things easier, like these electronic formats and stuff like that, but it would have to be dependent on the clinical area, complexity of the clinical area. But I mean, it's not really an irony, but the interesting thing is that PROMs are most useful often when dealing with chronic conditions over time. So they're really important to use, but then it's a little bit more complicated in how they're used, I think.
I think those are exact reasons that for integrated environment to have these conversations early on, because there's the opportunity to contribute to ideas. The tick-borne service is going to be addressing the same issues. So it's not about a clinic, it's actually coordinated consultation service. So how are we going to measure patient-reported outcomes? For every situation, so mine, for example, will be very different, very different line of service. So that's why I'm particularly advocate to is that we can explore this together. That means that it's not a cookie cutter, but it's sort of understanding what's out there. And what we're finding with the tick is there's not a cookie cutter, and here's the questionnaire. What we have decided is there are some standardized ones that we can know about. Let's use those, but it's not limited to that. So it's an open construct that needs to evolve.
Thanks for the opportunity to speak to you today.
I do have overviews of PROMs and PREMs for you.
national Canadian Institute for Health Information. I printed out your invite tours to have more information.